Just as a brief introduction to Dr. Vinod Chandan, he undertook his PhD program in genetic epidemiology with the University of Toronto Institute of Medical Science and will be defending his thesis in the near future. He was appointed as a faculty with the University of Toronto Department of Medicine and as a staff physician with the Division of Rheumatology, University Health Network in October of 2010. He is currently co-director of the psoriatic arthritis program at the Toronto Western Hospital. The Canadian Spondylitis Association and the Spondyloarthritis Research Consortium of Canada deals with spondyloarthritis, of which ankylosing is the largest or is the most common of the spondyloarthritic diseases. The cause of these diseases is all the same, but briefly put, it manifests itself in different ways. If it attacks your spine, it's ankylosing spondylitis. If it attacks your skin, it's psoriatic arthritis. My pleasure to introduce Dr. Vinod Chandan.
Okay. Thank you for giving me this opportunity. And I understand that we are short of time, and we'll quickly go through this. And before I start, I'll give my disclosures. I've received money from Abbott, Pfizer, Amgen. Many of these drug companies make biologics, and so, but that's my disclosure, but I get also money from the University Health Network and from CIHR and University of Toronto. So my outline of my talk would be to talk about spondyloarthritis in general. You might be a little confused now with ankylosing spondylitis, psoriatic arthritis, juvenile arthritis, what are we talking about? Is it all back disease, or is that more than just the back disease? I'll specifically talk about psoriatic arthritis, which is an arthritis that happens in patients with psoriasis and what its relationship is. Briefly talk about clinical features of this condition and what are the consequences of active disease, and then briefly on treatment. So let's start with spondyloarthritis. So by definition, the diseases that we all are talking about today is an inflammatory arthritis. And what is common between these diseases is that it has a propensity to affect the spine as well as other joints. And in the spine, you can see changes in the SI joints, either by X-ray or MRI. You have inflammation in the bowel, inflammatory bowel disease, Crohn's disease and ulcerative colitis, or inflammation in the skin, psoriasis. It tends to run in families, more so than diseases like rheumatoid arthritis. And a blood test that is commonly done to look for arthritis, inflammatory arthritis, which is called the rheumatoid factor test. Many of you might have gone to your doctor with arthritis, and they do a blood test and say, oh, it's negative, you don't have arthritis. That test is negative by definition, although some people might have a positive test. And some of them, and not everybody, has a B27 test. And positivity, which is again a genetic marker. It's more positive in ankylosing spondylitis, less than other diseases. But these are the 6 features that a patient with spondyloarthritis would have. It may have all these features, may have one of these features. And when you look at the constellation of diseases that come under this umbrella, there is ankylosing spondylitis, which I guess it's in the center because the spine is our center. The other diseases that we've talked about, that I'll specifically focus on, is psoriatic, but there is reactive arthritis, there is undifferentiated arthritis, there is juvenile arthritis, which Shelley talked about, and then arthritis associated with IBD. Again, it's maybe semantics, because if you have psoriasis and you get arthritis, you call it psoriatic arthritis. But if you have ankylosing spondylitis and then get psoriasis, you call it psoriasis associated with AS. Or if you have, it depends on when it came first. And so if you take a step back and look at it, it's probably the same disease with various manifestations, depending on what environmental influence or genetic background you have. And so you can look at families where, say, the father has ankylosing spondylitis, the daughter has psoriatic arthritis, somebody else in the family has just Crohn's disease with no arthritis. So because of the commonalities between these diseases and the genes that are common, you get various manifestations of the spectrum of diseases. So let's focus a little bit on psoriatic arthritis. It's a spondyloarthritis affecting patients with psoriasis, which, again, psoriasis, for those people who don't know, it's a relatively common inflammatory skin disease. Affects about 2 to 3% of the general population. It depends on the ethnicity. Some ethnicity groups have a higher prevalence, just like other diseases. And about 20–30% of patients with psoriasis eventually get psoriatic arthritis. So a large majority of them don't get it. And what is the relationship between psoriasis and psoriatic arthritis? About 70% of the people who have psoriatic arthritis, their skin disease comes first, and then eventually you get the arthritis. Not everybody, about 20–30%. And in 15%, you get both the skin disease and the joint disease at the same time, within a year's window. And in about 15%, you get the arthritis first, and then the psoriasis. And so since 85–90% of people have the psoriasis when they get the arthritis, if you screen patients with psoriasis, you can diagnose psoriatic arthritis or can diagnose spondyloarthritis early. So a lot of focus on early diagnosis, just like we focus on chronic back pain to diagnose ankylosing spondylitis early. If you screen patients with psoriasis regularly, you can diagnose psoriatic arthritis early. And so by doing that, you kind of capture almost the entire spectrum of spondyloarthritis. They can diagnose spondyloarthritis early by looking at patients with psoriasis and looking at patients with chronic back pain. So, does everybody with psoriasis get psoriatic arthritis? No. Are there risk factors that increase one's risk of getting psoriasis and then psoriatic arthritis? So psoriasis is, again, has got a strong genetic component. It has some environmental influences. Smoking increases the risk of getting psoriasis. Obesity is a risk factor for psoriasis. Now, once you have psoriasis, what are the risk factors of getting psoriatic arthritis? There are, again, genetic factors. For example, if you have psoriasis and you have B27, then you're more likely to get psoriatic arthritis. If you have psoriasis and you have HLA-C6, which is a risk factor for psoriasis, a gene that is a risk factor for psoriasis, you're less likely to get psoriatic arthritis. So there are differences there. And then other factors are injuries, trauma. So it could be injury to a joint or heavy activities. If your job involves a lot of lifting and pushing, that's a risk factor for getting psoriatic arthritis. Infection was found to be a risk factor, and body weight. People who have psoriasis, who are heavier, are more likely to get psoriatic arthritis. So, so there's genetic factors, which I guess we can't do much about, but there are a lot of environmental factors that are important, and if you understand that, you might be able to reduce your risk of getting psoriatic arthritis. Now, what is happening in these diseases? There is inflammation at particular tissues, be it the back, the joints, or the skin or the bowel. And what causes this inflammation? We really don't know. Is there an immune trigger that causes this? Again, we really don't know. No immune trigger has been identified except for reactive arthritis, which happens after you get a bowel or a genitourinary infection with particular organisms. But in AS and in psoriatic arthritis, there is no single trigger. There seems to be an excessive immune response to minor trauma. Just like in the skin, when you have psoriasis, if you injure yourself, you might get psoriasis where you had an injury, what is called a Koebner phenomenon. And it is possible that the arthritis is a deep Koebner phenomenon, that you get injury to your joints. So that's why your lower part of your spine or your legs, which has more biomechanical stress, that happens normally in every individual. But if you're genetically predisposed to spondyloarthritis, you have an excessive immune response in those regions, leading to tissue destruction, and then a reparative process where you have excess bone formation, forming syndesmophytes in the spine, or fusion of the joints in psoriatic arthritis. And one of the key molecules that is important in the inflammatory aspect of this disease is TNF. There's also a reparative aspect of the disease, new bond formation, where TNF does not play much of a role. So for taking care of for a drug molecule that causes more inflammation is TNF, and that's important because you'll come to that. I'll come to that later. So what are the clinical features of psoriatic arthritis? Most importantly, psoriasis. Without psoriasis, it's difficult to diagnose psoriatic arthritis, but you look for it carefully. You can have large plaques on the back. You can have small lesions on the skin called guttate psoriasis, or on the elbows. And most patients with psoriasis who have psoriatic arthritis also have nail disease, lifting and pitting on the nails. So when you come to go to your doctor, if you have psoriasis and you have nail disease and you have joint pain, then it's very likely that you have psoriatic arthritis. It can affect, when you talk about psoriatic arthritis, you have the spinal disease and the peripheral disease. And the spinal disease is very similar to AS, and so you all know that. So, but peripheral disease is also important. You can have inflammation in the end joints, the DIP joints, which can lead to destruction of that joint. You can see the X-ray here that's destroyed. You have other joints that can be affected. The hands, the feet, the knees, the hips. Sometimes can be really destructive and lead to shortening and flailing, flail fingers and digits. And so what we need to do is to prevent this from happening. You can affect the spine, like I said. You can have bony bridging between the vertebrae. It leads to a fused spine, fused SI joints, and also a fused neck, which is very similar to ankylosing spondylitis. Some other features which are more common in psoriatic arthritis is dactylitis, which is a swollen finger or toe. It can be just swollen without much of pain, or it can be swollen and painful. That's what and that's what is called an acute dactylitis. You can have enthesitis mostly around the knees. The heels. You can also have it around the knees. You can also, especially in children, have it around hips. And so that's inflammation where the tendon or ligament attaches to bone. So it's not exactly within the joint; it's around the joint. So you might have joint pain. The doctor looks at your joint and say, "Oh, there's no swelling in your joint," but the pain is in the enthesis, that is around the joint. So not exactly within the joint. And you can, when you do sensitive imaging with ultrasound or MRI, you can see that the inflammation is more around the joint than within the joint. But eventually, it leads to full joint inflammation. So let's talk about why is it important to treat. One thing, if you have inflammation in your joints, your spine, or your back, it leads to progressive joint damage and disability. So you need treatment to prevent that joint damage from happening and preventing disability. And early diagnosis and treatment is important. The more important thing that we realize now is that people who have inflammatory diseases, be it on the skin or in the joints, have a higher likelihood of getting heart disease, cardiovascular disease. And so if you look at the blood vessels in your heart, if you look at people who have had heart attacks, there is inflammation there. And when you have an inflammatory disease elsewhere, that inflammation in your blood vessels is more than what you see in people who don't have inflammatory disease. And so one of the important reasons for treating is not just pain and disability, but also preventing cardiovascular disease from happening. Previously, it was not possible because we didn't have enough therapy that would be effective, but now with effective therapy, we are seeing signs that maybe the prevalence of cardiovascular disease, or at least the incidence of heart disease, is decreasing, or we hope that it's going to decrease because we have enough data now to show that patients who have psoriasis and psoriatic arthritis and ankylosing spondylitis are, in addition to joint damage, they have more risk of cardiovascular disease. And so what we need to do is early diagnose and treatment so there is less damage, less disability, and less cardiovascular disease and other comorbidities. So let's come to treatment. How do we treat psoriatic arthritis? Now, when you look at psoriatic arthritis, as I said, there are skin and joints, right? So there are 5 domains that we look at. So when you go to a specialist in psoriatic arthritis, he's looking at 5 domains. He's looking at your skin and nails, he's looking at your peripheral joints, you're looking at your back, sausage digits, the dactylitis, and the enthesitis. So we have to assess these 5 domains and see how severe that is. And depending on if one of these domains are very severe, then we say that you have a severe psoriatic disease, and that has to be managed appropriately. So these are the 5 domains that should be looked at. I'm not sure if it's always looked at, but that's what we think we should do. And the aim of treatment is not just getting the number of joints down from 10 to 5, or it's not a 50% improvement or 70% improvement that we're aiming for. We're aiming for remission. Now, remission might not be possible, so we're talking about at least achieving a state of minimal disease activity, meaning a state where your symptoms and signs, as well as your blood work and X-rays, are in a state where is as low as possible, given the treatment possibility. So someplace, if there is no treatment available, then maybe achieving an MDA is not possible. But with newer therapies, achieving a state of minimal disease activity is possible. And we have to look at these 5 domains that I talked about before we can reach that state of minimal disease activity. And how do you treat psoriatic arthritis? Most importantly, I think the first thing is education, both to the patient and family members. Physiotherapy, occupational therapy, and management of comorbidities are important, and your treatment has to be in a multidisciplinary environment, looking at all these aspects And then pharmacotherapy is also important. And when you look at pharmacotherapy, meaning drug therapy, there are four classes of drugs that we use: NSAIDs, that is the usual painkillers, steroids, DMARDs, and biologics. So I'll go briefly through this. NSAIDs are, naproxen or Advil, Aleve that you can take either over the counter or from your doctor. For mild disease, it's okay. It's first line. It's acts quickly, provides some symptomatic relief. And if it's mild disease, you have no joint damage. Otherwise, you're doing okay with. And if NSAIDs relieve your pain, that's all that you need. Not everybody needs a biologic or a DMARD. Now, if you have more than that, you have to try what we call in psoriatic arthritis. These drugs don't work for the spine, but for the skin and for the peripheral joints, these drugs do have some benefit, but it has a slow onset of action. It broadly suppresses inflammation and immune reactivity, and is used in all but very mild cases. And the examples, many of you might have heard of them: methotrexate, leflunomide, sulfasalazine, and cyclosporine. Now, if you have your question is always there about steroids. Are they useful? They're useful for joint injections, not generally recommended as IM, IV, or by mouth, because they have a lot of toxicity. They can worsen the psoriasis. They're not been shown to be very useful for preventing damage. The biologics are the new class of drugs, which has been here for 10, 11 years now. It has a rapid onset of action. It blocks the TNF, which I said earlier was a key molecule that drives inflammation. And the examples that we have here in alphabetical order: adalimumab, etanercept, infliximab, and golimumab. These are the 4 drugs available, and one of them is IV, the rest is sub-Q. And essentially for the joints, they don't. You can choose one or the other. And so, what are the treatment effects of going on this drug? NSAIDs are good for joints. It helps with the back pain. It helps in sausage digits, enthesitis, but not in psoriasis. Whereas DMARDs help the joints and sausage digits may slightly, and some psoriasis, but does not have an effect on back and enthesitis. And anti-TNF agents have an effect in all the 5 domains that I talked about before. Now, what are the consequences of being on these drugs in the long term? The damage prevention has been shown only with anti-TNF agents. Cardiovascular prevention is shown somewhat with DMARDs, not in AS or PSA, but in other diseases like rheumatoid arthritis. And anti-TNF agents are also thought to help in preventing cardiovascular disease. And most importantly, safety concerns. With NSAIDs, we are worried about cardiovascular disease, kidney injury, and gastrointestinal problems. With DMARDs, you're worried about liver, kidney, and blood count. That's why you get your blood test done once a month. And with anti-TNF agents, it's mainly infection and inducing new autoimmune disease, which is a rare event but has been described. So that's all I have to say. We went through spondyloarthritis, the relationship between psoriasis and psoriatic arthritis, some of the clinical features, consequences of active disease, and treatment. And we'll have a good time during our session later on, and we can answer any of the questions that you have. This is the team which deals with psoriatic arthritis at the Toronto Western Hospital. This is the local team, and this is our international team. We do a lot of work on the genetics and outcomes of psoriatic arthritis within the SPARC and IPART networks. Thank you.